Hey everyone, and welcome back to Breaking Down Nursing. Today our focus is shock. What are the types of shock, and what are the stages of shock, and what do they mean? Before we dive into the different types and patho and signs and symptoms, and etc., let's talk about the four main buckets of shock. First one's hypovolemic shock, and this is referring to volume lost, either internally or externally. Next is cardiogenic shock, and that's referring to a pump failure, specifically meaning your heart pump. Then we have distributive shock, which means volume shifting, and this is due to increased capillary permeability, or what we like to refer to as fluid shifting into the third space. And then last but not least is obstructive shock. We like to think of this as a roadblock to the heart. Blood can't get in or can't get out, creating low volume. Let's start with hypovolemic shock. What is the pathology of hypovolemic shock? Well, this is severe loss of blood or bodily fluids, either internally or externally somewhere from the body. There's two main types of causes of hypovolemic shock. We have hemorrhagic, which is trauma that could be either internal or external bleeding, or we have non-hemorrhagic, which could be caused by things like severe vomiting, diarrhea, severe dehydration, and heat stroke. So what are some signs and symptoms specific to hypovolemic shock? We have a rapid, weak pulse, tachycardia, tachypnea, pale skin, severe thirst, low to no urine output depending on which stage we're in, restlessness and confusion. And of course, we'll talk about stages later on. We're just getting through the types of shock first. How do we treat hypovolemic shock? Well, first off, if they're bleeding, we gotta stop the bleed. If they're having a heat stroke, take them out of the sun, move them into a cool place. Then we're going to replace the fluid or blood loss. Once we've replaced the fluid or blood loss, then we'll start vasopressors. Always remember, especially when it comes to testing in NCLEX and in clinical situations, we need to replace volume before we can clamp down the pipes with vasopressors. Remember, if you clamp down your water hose outside, but you don't turn on the water or very little water is going through, you're not going to increase pressure. So we need to fill the pumps before we can squeeze them. Next is cardiogenic shock. This is our heart pump failure, leading to severe hypotension. Usually our ejection pressure, or the percentage of blood pumped from the left ventricle, is less than 30%. Some of the common causes of cardiogenic shock include myocardial infarction or heart attack. That's usually our most common. Heart failure in the end stages, or valve rupture, which is less common but just as severe. Some specific signs and symptoms of cardiogenic shock would include tachycardia, weak pulse, cold, clammy skin, shortness of breath because of fluid backup. When the heart's not pumping adequately, remember the fluid backs up into the lungs, especially if it's left side heart failure. So shortness of breath would definitely be a huge sign and symptom, along with crackles, tachypnea, low O2 saturation, and of course low urine output and restlessness. How do we treat pump failure? We treat the cause. If it's heart attack, they need to go directly to PCI or a heart cath. If that doesn't work, they may need a CABG or a bypass, and of course O2. Heart attack or the heart failure has already happened, we may need additional support, IABP, or a VAD, ventricular assist device. And of course, ECMO is always an option. Our pressors for treatment for cardiogenic shock is not norepi as first line. Remember, our problem is our pump has failed, not that we need clamped down vessels. We would look to things like dobutamine and dopamine to help with contractility and getting the pump to work better. Remember, if we have to give fluids, and sometimes we do in cardiogenic shock, we give them at smaller doses over a longer period of time. The pump is already failing. We don't want to overload it and cause more respiratory distress. It's not that we can't give fluids, we just have to do it safely. Next up is distributive shock. We actually have 3 different types of distributive shock. The reason why we have 3 very different types of shock in distributive shock is because the patho at the end of the day is all the same. For distributive shock, we have a severe vasodilation, which is caused by an increased capillary permeability, leading to severe third spacing, or fluid going into the tissues where it should not be, and out of the vascular space, causing hypotension. Now, of course, these 3 different types of shock are all caused by different reasons, but the end result is all the same. The fluid shifts into the third space, creating the patient to go into shock. So the 3 types of distributive shock include septic shock, anaphylactic shock, and neurogenic shock. And as you can tell, all 3 are very different in origin or causes, and we treat them differently as well. Let's start with septic shock. Septic shock is a dysregulated immune response to an infection. A pathogen comes in, either viral or bacterial, causes an overwhelming systemic infection, and leads to increased capillary permeability from the release of histamine from mast cells. That increase in capillary permeability allows for white blood cells, neutrophils, and lymphocytes to get out to kill and destroy the invading pathogen. Of course, your body can't just tell your white blood cells to leak out by themselves. Unfortunately, that means that also fluid leaks out as well, and plasma. And that allows that fluid to shift into your third space. But always remember that if we can fix septic shock or distributed types of shock, that fluid will then shift back into the vascular space once we've clamped down the vessels and fix the problem. When the patient starts to get better, that fluid will shift back in and they'll self-diurese that extra fluid right back out. So some of our signs and symptoms of septic shock depend on the phase. We have two types of septic shock. We have warm septic shock and cold septic shock. Warm septic shock includes cap refill less than 2 seconds. This is when patients get fevers, bounding pulses, tachycardia, and of course the warm flushed skin. As they shift into cold septic shock, which is our later version of septic shock, that is when they start to become cool, clammy skin, cap refills less than 2 seconds, weak pulses, tachycardia, and hypotension. Our treatment for septic shock is the same regardless of which phase they are in, warm or cold. We always start with our ABCs first. Make sure their airway is good, make sure their oxygenation and ventilation are adequate, and then we work on circulation. So fluid replacement starts at 30 mLs per kilo for an adult. Of course, we can always give more, but that is our baseline for administration. Remember, we also have to get blood cultures, and then we give broad spectrum antibiotics. On tests, they'll ask which one comes first. Remember, cultures always come before antibiotics. And of course, lactic acid. Our goal is to have a lactic acid of less than 2. If our lactic acid's elevated, we know that the mortality rate for septic shock increases. Our goal is to increase perfusion to get that lactic acid back down. Remember, lactic acid is a byproduct of anaerobic metabolism. Our cells are not getting the perfusion needed to create ATP. The higher the level of lactic acid, the worse off the patients are. And of course, last but not least, are vasopressors. Our vasopressor of choice for septic shock is normally norepinephrine or Levophed. Next up is anaphylactic shock. This is also distributed shock. It's a severe life-threatening systemic allergic reaction due to a histamine response from an allergen, increasing capillary permeability. Signs and symptoms of anaphylactic shock includes things like angioedema, and that's face, lip, and tongue swelling, stridor, which is an upper airway obstruction or partial obstruction, wheezing, which is a lower airway partial obstruction, hypotension, hives, itching, nausea, vomiting. They could have a sense of impending doom, dizziness, and tachycardia. So when trying to differentiate between anaphylaxis and other shocks, remember that hives, itching, and angioedema are very specific to anaphylactic shock, and those will lead us down the anaphylactic shock pathway. Our treatment is of course epinephrine first, an IM injection, oxygen to keep their SATs above 94%, IV fluids to manage hypotension. We would give Benadryl for its antihistamine effect, corticosteroids to help to decrease the inflammatory response, and H2 blockers. These help to blunt the histamine release. Next up is neurogenic shock. Now, neurogenic shock seems to be like the one that just kind of got tossed into the distributed shock pathway. But remember, it's not the cause of the shock that categorizes it. It's the pathology of what's happening and the end result that then categorizes it into the distributed shock category. So for neurogenic shock, it's an acute spinal cord injury, usually at the T6 level and above, that leads to a loss of sympathetic tone and unopposed parasympathetic activity. This then leads to increased capillary permeability. Some signs and symptoms of neurogenic shock include hypotension, bradycardia, warm, flushed skin, and of course respiratory dysfunction. So when getting a question on a test about neurogenic shock, patients that are bradycardic and just had a spinal cord injury, you would start thinking down the neurogenic shock pathway. Most other shocks, if you've noticed before, the compensatory mechanism for our heart when we start losing cardiac output is to become tachycardic. In neurogenic shock, we're unable to do that because there's a core disconnect between the level of injury and above. And so the brain has no idea of what's going on at the level of injury and below, because the communication is disrupted. So your body is not able to compensate like it normally does, which leads to profound hypotension and bradycardia. Treatment, of course, is spinal precautions. Make sure that C-spine's intact. Make sure that we put them on a spinal board if we're trying to move them. All the spinal cord precautions. IV fluids and vasopressors. Our vasopressor of choice For neurogenic shock, maybe something like dopamine that has both a assistance with bradycardia and as well as assistance with hypotension, increasing that heart rate and increasing the blood pressure. And of course, in severe cases of bradycardia, we can always use atropine to increase our heart rate. Let's move on to obstructive shock. I always like to think of obstructive shock as like a roadway blockage. So I don't know if y'all have ever lived in Florida before, but I used to live in Florida and we had these things called Bob's barricades. And Bob's barricades, because we're always working on our roads in Florida, we're everywhere all the time, obstructing our driving pathway. I always think of obstructive shock as a Bob's barricade. It's a physical obstruction preventing adequate blood flow into or out of the heart. This then impairs preload and increases afterload, neither of which our heart really enjoys or likes. Some of the causes include things like pulmonary embolism, a very large one, tension pneumo, because we're starting to compress on the heart, and of course cardiac tamponade. Some signs and symptoms include tachycardia, weak thready pulse, cold clammy skin, chest pain, shortness of breath, tachypnea, restlessness, JVD, and tracheal deviation. Looking at treatment, we have to treat the underlying cause. As we're treating the cause, oxygen first. For a PE, we may need things like thrombolytics or anticoagulants or a trip to the IR. For a tension pneumo, they'll need a needle decompression, and then of course they'll get a chest tube afterwards. And then for cardiac tamponade, they may need a pericardial centesis or even pericardial window in the OR suite. Moving on to the stages of shock. We just finished talking about the different types of shock. Now remember, we have very different causes of shock that we just walked through. All shocks go through the stages of shock. However, how fast they go through them is very different depending on the time frame. For example, a patient in sepsis or going into septic shock may take days to weeks, whereas somebody who has a tension pneumothorax or obstructive shock could go into with minutes to maybe even an hour. So the stages are always the same. It's just the time in each stage may change or may be variable based off of the type of shock they have and of course the injury itself. So there's 4 main stages of shock. We have the initial, which is our actual exposure, trauma events. This reduces the O2 to our tissues and we start to go into anaerobic metabolism. Now at this stage, we may not actually see any overt signs and symptoms. Our body has a great ability to compensate until it can't anymore. Our next stage is the compensatory stage. This is where our body attempts to maintain cardiac output or CO. Some signs and symptoms would be increased heart rate, respiratory rate, anxiety, restlessness, pale, cool skin, normal to mild blood pressure changes, but we're still maintaining a blood pressure. When we shift into the progressive stage of shock, our compensatory mechanisms start to fail. We'll see an obvious drop in blood pressure. When we see this drop in blood pressure, we know that we have transitioned from compensatory to progressive. And that really is the linchpin between them. This then causes hypoperfusion. Some signs and symptoms we may see are things like confusion, weak pulses, rapid breathing, decreased urine output. The last stage of shock is refractory. This is when the patient starts to have multiple organ failure. We could see brain damage occurring with changes in mental status, potentially decorticate and decerebrate posturing, and it'll lead to impending death. Our job in healthcare is to identify the stage of shock as quickly as possible. If we notice that a patient's going into shock, we want to catch it preferably in the initial or compensatory stages. The more advanced stages that the shock gets to, the harder it is to be able to turn around a patient. Shock is not just low blood pressure. It's cellular death happening in real time. By the time you see hypotension, your patient's already in trouble. Catch it early, treat it aggressively, and always ask yourself, is perfusion adequate? As always, thanks for watching. If you want more breakdowns like this, hit the subscribe at the bottom. And of course, as always, stay safe.